Module 3, Techniques. My nurse has high hopes. I am ready to learn the ropes. So I made this little acronym in terms of the pouch change procedure. So you read stoma over there on the left. So this works for the new ostomy. Once the stoma size is not changing, then the pouch obviously can be all prepared prior to removing the old pouch. It's also a really good habit to have them observe the back of the old pouch barrier because that will show if there is undermining of the output to the seal. So set up supplies. So the pictured supplies here include the paper stoma measuring guide, and these are included in the manufacturer's product with the pouches. If you do not have a guide, you can make one. Measure the length and width of the stoma, mark these measurements on a piece of paper or an index card, or maybe the plastic from the back of the pouch packaging, and cut a template using those marks. And a curved scissor is shown here as well, and that makes cutting the barrier easier. If it's not available with the patient supplies, you could request it from the supplier when you're placing the order, or the patient could look to buy a small scissor from a craft shop. Once the stoma size is stabilized, then a pre-cut barrier may work, and then scissors are not needed at all. Pictured here are what we call accessory supplies. So accessories are items that may or may not be needed for routine ostomy care. Less is best when it comes to ostomy pouching. I'm going to show you the most common accessories. There's many more that exist on the market. The pictures shown here are all items that serve to create a tighter seal, so they function like caulking between the pouch barrier and the skin. They protect the peristomal area from excessive moisture, which pertains especially to ileostomy and urostomy. And all versions are used for uneven skin surfaces to create a flat pouching surface. The barrier rings and strips are alcohol and sting-free. The tube paste often does contain alcohol, which keeps it with a toothpaste-like consistency. If the paste contains alcohol, it would sting if placed on open or irritated skin. Emphasize to your patient that the paste is not glue. If using paste, then a thin ring is applied to the back of the barrier around the cut opening. The rings and the strips are moldable. You pull them to fit around the back of the cut barrier, or use pieces to fill in dips or creases around the stoma. I've also shown it here where I've molded the barrier onto the patient's skin directly before putting the pouch. Either version is right. It's whatever is easier for your patient. In general, the solid forms, the strips and the rings, hold up better to liquid output. Another common accessory are adhesive removers. That term is very broad. In this context, the purpose is to make the ostomy pouch removal less traumatic. There are alcohol-free versions available, which make them sting-free. Using these may help the new ostomate as they gain confidence in managing pouching. Adhesive removers also help lift off residue from the barrier paste strips or rings. Since these wipes are typically packaged like an alcohol wipe, your patient may assume they are alcohol wipes. What we have pictured here is a skin sealant, also called a barrier film, which combines a plasticizing agent plus alcohol or silicone in a wipe or spray form that provides a protective film on the skin. No sting versions mean they contain silicone rather than alcohol. This product is used to seal ostomy powder or antifungal powder. This is known as crusting technique and will be explained later in the module. Do note that skin sealants are not recommended with extended wear barriers. Reinforce to your patient that this is not a cleaning wipe, nor is it always a necessity. So when they're removing the pouch, they want to be gentle about it. So we call this the push-pull technique. So you gently push down on the skin while you're peeling back the barrier. Using a warm, moist washcloth or a paper towel with an adhesive remover wipe may make this more comfortable. Emphasize, do not rip the pouch off like a Band-Aid. So to determine the size of the stoma, and then you trace that template size onto the back of the pouch barrier and cut. You cut on the outside of the line that you've drawn so that you avoid making the opening smaller than that template. And if need be, you can cut off center if that will allow the pouch to avoid an incision line or another tube. In this image, I just want you to think about which size is optimal. And the answer is the picture on the left. We want a snug fit. And we don't want it cutting into the stoma, but it is fine for that barrier to sort of kiss the stoma. A too large opening means the skin would be exposed to the output. Then you're going to assemble and apply the pouch. So after the barrier opening is cut, you warm the barrier or the back of the pouch in your hands for a few minutes, as this can speed the adhesion once on the skin. If using a two-piece system, the patient can choose to put the barrier first as pictured, and then the pouch can be snapped on, or they can do it all off of their body and put it on as one unit. Of course, you'll remove the paper backing from the barrier or the pouch. If you're using the paste or rings or strips, then apply that to the back of the barrier and then apply the pouch. Press gently and have patient hold their hand against the barrier. Again, that warmth will help to activate the adhesion. And your patient will need to sit or stand to do this. Be sure and close the end of the pouch. Urostomy pouches have a spout. The fecal drainable pouches have that built-in closure that roll up and are secured with a Velcro or Velcro-like closure. There's references on each of the manufacturer sites for their products and specifically. Less likely, but your patient may be sent home with a pouch that uses an external clamp. These are functional but harder to manage, so you can definitely help your patient by requesting samples of the pouches with an integrated closure. And as mentioned, we have links to the manufacturer's website attached to these modules. The overall theme here is we want to empower our patients. So your patient may not have done much hands-on care while in the hospital or other facilities, or their significant others may have been taught the pouch change technique. Once the patient is home, it is key, if they are physically able, that they learn self-care, even though they may not be initially willing. Given limited home health visits means that from the initial visit, the patient, again if able, should be participating in the pouch change. Reassure them you are there as a coach. After you have developed rapport with your patient, it is also helpful to ask and acknowledge what feelings they have regarding the diagnosis and the ostomy. A common fear is of pouch leaks. Best to be real, as leaks, although not common, do occur. Of course, frequent leaking is not normal, and you need to look for the cause and help provide the solution. If the problem is beyond your abilities, then reach out to a certified ostomy nurse. Linking them with a local or online support group provides another wonderful tool for adjusting to life with an ostomy.